Welcome to this afternoon's discussion on Vanilla Sky. So, where does the group want to start? There's no way you're convincing me that there's nothing psychiatrically or psychologically going on in this movie.
Maybe start with David.
Who?
David.
David. All right, so what did you say?
Well, throughout the film, he kind of alternates between what he perceives as reality and dreams. And then later we find out that his interpretations were all based on this life extension program where he's almost in a matrix situation where his reality is actually just computerized. At least that's what he believes.
Yeah, well, okay. So I was going to actually just bring that up. David's here, and his chief complaint is along the lines of now what we understand to have been going on for the last few weeks to months, maybe longer. What's running through your collective heads as a clinician?
Maybe investigating something like schizophrenia, so if there are hallucinations and delusions.
So we think that this might be a psychotic process. So if we were to, again, reapply the algorithm that we usually apply when it comes to case formulation and go by way of a mood anxiety cluster or a psychotic dissociative cluster, is the consensus choice B, psychotic dissociative cluster? And if choice B, arbitrarily, we're going to agree to start with schizophrenia. Part 3, number 3, would be to demonstrate your knowledge of the DSM and then provide me the A criteria or the inclusion criteria for this condition called schizophrenia.
Hallucination.
1,
And delusion.
2, 3 more.
Greater than 6 months.
True. Yep. I heard.
Negative something.
3,
Disorganized speech.
4,
Disorganized behavior.
5. All right. How many do we need? Does David rule in here?
Does
Got nods. So I guess, and maybe I think so.
what is what rule in?
David.
That's what you said.
Yes, he
does
ruling
David
in.
rule in.
Yeah. He need, do we see at least 2 of the 5 you just mentioned? Which ones?
Hallucinations.
Delusions.
Yeah, delusions, right? All right, so there's at least 2. At this point, we'll get to the time frame in a second, but at this point, we then acknowledge and appreciate that schizophrenia is a diagnosis of exclusion. And as a diagnosis of exclusion, we have to now consider 5 illnesses to investigate and then rule out in order to continue to rule in schizophrenia. So what are those 5 conditions?
Delusional disorder.
Sorry?
Delusional disorder.
Actually, we don't have to. Even if he rules in for delusional disorder, schizophrenia would take precedent.
Schizoaffective.
Schizoaffective disorder. 4 more.
A mood disorder with psychotic features.
Good. 3 more.
ASD.
Autism spectrum. 2 more.
Substance use.
1 more.
And I think most prevalently in this, I would say, is underlying medical condition.
Underlying medical condition, right? Any of these at the top of your differential to discuss?
Underlying medical condition.
Yeah,
From
so-
the accident. TBI.
TBI. That's a concern. All right. Timeframes will establish if we see no evidence of what we're referring to or are interpreting as psychosis prior to the event. Certainly, that temporality does support that his psychosis is secondary to an underlying medical condition, specifically traumatic brain injury. It's a consideration. How about substances?
I don't think we see that he's anything other than alcohol.
Can alcohol induce psychosis? Yeah. How? Just 3 answers here. Not necessarily demonstrated by David, but just in general on a shelf exam, let's say. The 3 ways in which alcohol can induce psychosis?
Drinking too much,
Intoxication.
withdrawal.
2. What? Are you sure? Okay. As you're thinking of the third situation, the third answer, I want to talk a little bit about withdrawal because on shelf exams, this comes up in one of two ways. A person comes in who is in active withdrawal, so they're ruling in for alcohol withdrawal. On a shelf exam, pathognomically, day 3, right? So just red flag day 3. And is experiencing hallucinations, maybe even visual hallucinations, seeing snake spiders crawling out of the wall. What's your differential diagnosis there with regard to alcohol-induced psychotic disorder, withdrawal phase? There's two other conditions, or two conditions, maybe subcategories of this that you have to consider.
Like alcoholic hallucinosis versus delirium tremens.
Right? And the difference?
I suppose delirium tremens has more of the systemic effects where you'd see like vital sign derangement, where you might not see that with alcoholic hallucinosis.
You could.
Okay.
Since both are due to withdrawal, that the vital sign derangements, the autonomic instability is going to be due to the withdrawal state, even with or without the perceptual disturbances. Alcohol withdrawal delirium versus the condition previously known as alcoholic hallucinosis, currently DSM-5, alcohol-induced psychotic disorder. Right? So just remember both terminologies. There is one thing that often appears on shelf exams that helps differentiate.
Time course?
No. It's not time course. Sensorium. If a patient is awake, alert, and oriented, it is likely to be alcoholic hallucinosis / alcohol-induced psychotic disorder. If they are disoriented, they're likely delirious. So there it's alcohol withdrawal delirium, formerly known as delirium tremens or DTs. Right?
Can you say that one more time?
Yeah. So sensorium, whether the individual is awake, alert, and oriented. So if the individual is disoriented, the presentation is consistent with delirium in general, and therefore alcohol withdrawal delirium is the single best answer, formerly known as delirium tremens or DTs. On the other hand, if their sensorium is intact, if they remain oriented, then the most likely answer is going to be alcohol-induced psychotic disorder, otherwise alcoholic hallucinosis. Those two terms are interchangeable. In either case, alcohol withdrawal is one of the three ways in which alcohol can induce psychosis, other than acute intoxication. What's the third?
Is it cerebellar degeneration? I feel like I'm going on the wrong track.
You're close.
Oh, like Wernicke.
Yes. Yeah. Right. The Wernicke's-Korsakoff syndrome. What is Wernicke's encephalopathy? What is Wernicke's delirium?
Thiamine deficiency.
Right? So it's a delirium, an encephalopathy that is the result of thiamine deficiency from any cause, but alcohol or chronic alcohol ingestion is the most common. What's the triad? Other than delirium, what's the other two parts of the triad?
Nystagmus.
Yeah.
Disturbance.
Yep. The nystagmus could be also part of a continuum with ophthalmoplegia, right? Usually we remember the triad with the acronym COAT. So there's confusion due to the encephalopathy, ophthalmoplegia, ataxia, and then thiamine deficiency as the cause or thiamine to treat. If left untreated, a significant portion of individuals with Wernicke's encephalopathy progress to a potentially irreversible neurologic syndrome called what? Korsakoff psychosis, which also has its own triad. What is a triad of Korsakoff psychosis? Other than psychosis, what are the other two parts of the triad? amnesia. And what is a clinical finding at bedside in any amnestic patient that you could uncover? As you're providing a quick 30-minute assessment for a follow-up patient who has amnesia due to any cause, especially dissociative states, what's something that they might do that you pick up as a clinical finding? What is confabulation?
Filling in gaps.
Right? Filling in those gaps with false memories, confabulation. Is the amnesia due to Wernicke's Korsakoff syndrome retrograde, anterograde, or both? Both. Right. So, and with that, we have the acronym RAC. So there's retrograde amnesia, there's anterograde amnesia, there's confabulation to fall in those gaps, and the K is Korsakoff psychosis. Right. So Wernicke's Korsakoff syndrome, CORAC. I did not make that up. That was not improv, and a year ago, 10 years ago, that was not mine. All right, back to our main character. And the differential diagnosis in working up his apparent psychosis. Medical condition, substances. I mean, there might be some combination of sedative hypnotics and even narcotic analgesics that he's taking too. He's dipped into the medicine cabinet more than once. So I'm not so sure that we're not seeing something that's drug-induced. Right? And while opioids are not considered to induce delirium, as per the DSM, as part of the American Psychiatric Association, alcohol and benzos can. So it's a consideration that it might actually, I think we need to keep that in a differential diagnosis. All right. Other aspects of this movie pertaining to David that you observed? Do you like him? Yeah? Why not?
He's slimy and selfish.
Mm-hmm. Do we think that personality trait is something that might become clinical significant? Does it cause distress or impairment in functioning?
Probably impairment in functioning.
How so?
He doesn't have many close personal relationships, and it's also affecting his professional relationships.
Yeah. Yeah. What does he call the board? The board of trustees? Yeah, he's very, very condescending. Yeah. Mm-hmm. Now, part of that might be the board of directors not necessarily thinking he is competent to be in the position that he is, and the only reason why he is there is due to nepotism. So, how might we get to understand that and that dynamic, in as much as trying to figure out what makes this guy tick? I mean, as a clinician, as a future psychiatrist, you're probably going to have to come up with some treatment plan to delve into this if we want to change David's behavior, assuming that he's alive at the end of this movie. So, how do you figure out the chicken or the egg? Remember, even though I think it's universal that our initial thought is along the lines of what biopsychosocial factors are contributing or influencing a person's behavior, and therefore a person's abnormal behavior, so too do predisposing, precipitating, perpetuating elements. And if you build a 3x3 rubric and you begin to put your clinical findings into those 9 squares, you're going to get a great visual of what makes that person who he or she is. And the fact is that if we, through establishing time frames, uncover the idea that David has pre-existing traits along the lines of cluster B, maybe even narcissism, prior to his even working for his father, much less getting the position that he gets, then you're likely looking at that dynamic between the board of trustees and David Ames as perpetuating factors, right? So, and that's got to inform your treatment plan, if not your psychotherapy, right? And we could see how you're taking the history and the time frame suggesting otherwise would completely change that, right? So when a patient presents, they're going to give you that cross-section slice of time. To make the best sense of it, you do have to establish time frames, because the same exact information contained in a different time frame leads to different conclusions, and you can't miss that. Miss that is to miss the diagnosis, and if you miss the diagnosis, there's no way you're getting a treatment plan that's correct. Other thoughts about David? So the last step in the process of the formulating or most likely diagnosis is to go through the thought exercise that if we've taken notes and if we now cross off everything that's in front of us with everything that we just discussed, would there be any information left? Because if the answer is no, then we've synthesized all the information that is available to us. However, if you're still seeing something in front of you that is not explained by schizophrenia or schizoaffective, drugs or an underlying medical condition, autism spectrum, we have to come up with secondary or perhaps even tertiary diagnoses to explain it. So is there anything that's still out there to discuss?
I don't think this would necessarily impact any diagnosis, but the scene where he's like in prison and continues to keep the mask on despite the, I don't know, the figure he refers to as almost like a father figure with glasses on, says something like, like your face looks fine under there. I thought that was interesting. I don't know if I missed the detail and they actually kind of explained why he was doing that, but it seems kind of like an interesting avoidance behavior despite there being verbal validation that there's nothing wrong underneath the mask.
Interpretation? I mean, we've watched and we've discussed David Fincher 7, and there's a line from that movie that I think is almost interchangeable with what you just observed, right? Someone who was so ugly on the inside that she couldn't bear to, complete the sentence there. So you're definitely getting at a significant character pathology and likely personality disorder in terms of vanity, and that still places us in cluster B. I also found that, looking back now at the derivation of the term of narcissistic personality disorder, the symbolism of mirrors in this movie is very interesting, especially in David's room, this house, apartment. Mm-hmm. Which connects really nice to the Disney theme, right? Nobody watches Disney and glosses over the magic mirror, right? Or if you have glossed over, you missed a big part of what those stories are about. Final thoughts on David? Is there anything else? I think there's something that's so obvious you guys are just assuming that we've all understand it and don't want to bring it up for further discussion.
I mean, he seems pretty, very not emotionally reactive to the death of Julie, which I found interesting. He almost immediately started, deferring thoughts to Sophia and, how he would win her back and such with his disfigurement.
Mm-hmm. That doesn't surprise me. Yeah, I think it's the script gets it right there in terms of the character they're trying to build, right? But you're right. There's nothing there, right? Which again gets that why he needs that mask. Mm-hmm. What chapter of the DSM do you think David ultimately lands in? Obviously, the answer is not, in my mind, at least trying to read my mind, the answer is not the schizophrenia spectrum and other psychotic disorder chapter. I'm obviously getting at something else.
Personality disorders?
That's true. I think we could even look beyond that. Although I don't, that's true. What's the big reveal at the end? So spoilers for those following us on the stream.
He wakes up right at the end. So
From what?
be all a nightmare. Could be that he really was frozen and then thawed.
So what is Vanilla Sky really about?
Nightmares, dreams.
Yeah, that's sleep pathology, right? We're probably going to land in the sleep and wake disorders. Yeah. This particular company advertises and primarily focuses on lucid dreaming, right? So if that's the case, what are some thoughts that go through the clinician's head?
Night terrors?
Why night terrors?
I'm just thinking of a diagnosis related to that.
Yeah, I mean, I think we said nightmares, and night terrors have to be in the differential diagnosis, and especially because they usually do appear. A and B, B and A on shelf exams. So how are you going to differentiate the nightmare from the night terror, and therefore nightmare disorder versus sleep terror disorder?
Sleep terrors are usually earlier in sleep, and they're not consolable, and nightmares are usually later, and they are.
Why are nightmares later?
Because they're a REM disorder, and sleep terrors are NREM.
Right. Are you telling me then that the preponderance of REM occurs later in the sleep cycle? That's exactly right. Words in your mouth. Yep, exactly right. Everybody got that? I mean, we have a REM versus a non-REM condition. REM occurs usually occurs in the last 2/3 of the night, whereas the opposite is true for non-REM. Those non-REM cycles. So we would expect to see a higher incidence of REM-related disorders or REM disorders in the later half of the sleep cycle towards morning. And the opposite is true for the non-REM related sleep disorders, including but not limited to sleep terror disorder. Let's say, though, in your shelf exam, you get no EEG and you get no information on where in the sleep cycle the individual is experiencing A and or B. What else you're looking for in the clinical vignette that's going to allow you to say sleep terrors versus nightmares?
Do they remember the dream?
Exactly, right. People remember their dreams, and therefore people remember nightmares. And you could forget, and there are dreams that we don't remember, but if you are remembering, again, remember REM, REM-related, that's nightmare disorder. Individuals will not remember anything that occurs during non-REM periods, and that includes sleep terrors. And then the other biggie is that the person with a sleep terror disorder usually wakes up disoriented with a higher degree of autonomic arousal compared to somebody waking up from a nightmare. What is another condition, or what else should we consider within this same discussion regarding the lucidity of his dreams? So I think there's two things we still have to discuss yet. I mean, if you came to me and said, Doc, I'm here to see you because of recurring nightmares, obviously I'm going to ask you, does this in any way impair functioning, cause clinically significant distress in yourself, others? But there are also related questions I'm going to ask.
Regarding lucid dreams? Or like regarding lucid dreaming? Or
Like something to do with muscle paralysis? Like
Why?
because in REM you have your muscles are paralyzed versus in REM you're not. So like there could be sleepwalking or something as well. Sleepwalking.
Sleepwalking would be another non-REM condition, yep. But there's another reason why I want to ask about muscle paralysis, sleep paralysis.
Like REM sleep behavior sleep disorder.
We could definitely get into the complete differential diagnosis, no doubt, and no doubt during a clinical encounter you're probably going to. But what's the reason that cuts across all of this? What am I trying to get at here? There's some asynchrony with regard to when one cycle shuts off and the other cycle begins, right? When that happens, we could actually have maybe a stage 1 or 2 sleep where we should have REM shut off, right? The microarousal, right? The K complex, right? And the sleep spindle. And if we are still REMing during those later stages of sleep, stages 1 and 2, we can get lucidity, right? So, because they should not be happening, or they should not be co-occurring. So there's the asynchrony that's concerning. Now, why might there be asynchrony? Well, there's two answers here. One is there might be a sleep pathology, right? Narcolepsy is one, and we can go through the entire differential diagnosis. What is the other potential reason for asynchrony lending to the lucidity of a dream? Drugs. Drugs annihilate the REM architecture, right? The sleep architecture. And therefore, you're going to have significantly higher risk of having some asynchrony. And with asynchrony, you can get lucid dreaming. What is by far the most common example of this on shelf exams? Benzodiazepines, decided hypnotics. Which, by the way, David is taking. Other observations, characters other than David Ames.
A question, does narcolepsy count as lucid dreaming?
So, yes. The simple answer is yes. The question is about narcolepsy and lucid dreaming. Narcolepsy is defined through the asynchrony. There's REM intrusion into a lighter stage of sleep and even wakefulness. And that's why we could have episodes of catalepsy and the drop attack as a result. So, yes. The treatment of which is what, by the way?
Modafinil?
Yeah. Why? Usually prescribed in the morning.
The orexin thing?
Sorry?
The orexin something, or am I mixing?
That comes next.
Oh.
Yeah. The stimulant is usually provided to address the excessive daytime sleepiness. The other medication, which also includes GHB, although it's marketed under a much different brand name, is usually given outside of the morning, and it focuses primarily on the drop attacks. Right. Other characters.
Julie?
What's going on with Julie?
I mean, if she's just a figment of David's imagination, then it's probably not worth analyzing her personality. But
Why do you say she's a figment?
we don't really know when the dream started, assuming David is dreaming. She also, I mean, doesn't really exist outside of David. Like, she kind of mirrors back to him what he believes of himself. She's sort of this, like, amorphous dream girl that doesn't behave how a rational person with agency would.
Mm-hmm. How would you compare her character to, I'm blanking on her name now.
Sophia?
Yes, please. And I guess I'm also going to ask if Sophia is also perhaps a figment of David's imagination. And if so, what does that mean?
It's unlovable. They're supposed to be the imaginary partner.
Mm-hmm. Can't argue with that. Sophia looked like a carbon copy of Julia? I got a couple of shakes now. Why not?
It's kind of like the Madonna horror dichotomy, but split into two characters. I feel like Julie represents everything that's like the, you know, she's sexy, she's a status symbol, and she's got a little more edge to her, versus Sophia is just like kind and warm and endlessly forgiving and artsy and.
Yeah. I mean, it would be overly simplistic, but they do look like polar opposites. Right? Something to that?
I feel both sides of the world. It's like if you have a nice wife, you will want someone that's more fun as a mistress.
It's fair. Yeah, so I think I would definitely start with that consideration that this is perfectly normal, right? And as a psychiatrist, again, you've heard me say this before, and to your point, and with regard to this issue we're discussing, in Vanilla Sky, at first glance, completely normal, right? Now, if there's evidence to the contrary, which there might be, and I'm specifically looking at the idea that maybe neither of these women exist, we may have to delve in this a little deeper. And in doing that deep dive, we're probably going to transcend beyond the normal. We're going to explore why this may be abnormal and perhaps even disordered in as much as it's causing clinically significant distress or impairment. So, from that perspective, any other thoughts here?
I guess it could be like a difference between like ideation of what he wants in his own like mental capacity versus what he actually got before the accident and what he had, which is sort of why I always try to analyze like characters that are just interpreted as just like visions or figments of your imagination, because you can kind of tell a lot about the person imagining them by seeing like she's so different from which one, whose names again? So one was Sophie and one was Julia. Like the difference between them really can potentially point to like the difference from ideation to reality in terms of like what he wants and what he has.
And what might it tell us about David?
Would you consider this splitting?
I absolutely consider splitting. Yeah. Yep. Anytime you use the S word in psychiatry, our minds automatically go to borderline personality disorder. We've already talked about the cluster B personalities related to this character. Would it really be out of the ordinary? Would it really be a stretch to consider that he has maladaptive borderline traits in addition to his narcissism? It's likely to occur. That's why they cluster. Yeah. It's a little bit beyond the scope of our discussion this afternoon to go through, I think the 9 criteria to see if he reaches 5, but that would be part of the psychiatric assessment for sure. Right? All right, final thoughts. Vanilla Sky. We're good? We'll leave it there. All right. We are close to deciding what next week's film is about. We're trying to coordinate with the psychiatry interest group. Hopefully we'll get that out later today. If not, it should be by tomorrow. All right. Final thoughts? Final questions? We're good. Thank you, everybody.
Do you think that the